Good morning to everyone. I am Sajida, Assistant Professor in Manchester College of Nursing. Today we are discussing about the topic of thoracosynthesis. First of all, discuss about the objectives of the thoracosynthesis. Definition of the thoracosynthesis. Describe the indication for thoracosynthesis. Describe the contraindication for thoracosynthesis. Procedure for thoracosynthesis and complications of thoracosynthesis, relevant management and strategies. Overview. Thoracentesis. Thoracentesis is a procedure that is done to remove a sample of fluid from around the lungs. The lung is covered with a tissue called the pleura. The inside of the chest wall lined with pleura. The space between these two areas is called pleural space. This space normally contains just a thin layer of fluid. However, some conditions such as pneumonia, some types of cancer or congestive cord failure may cause excessive fluid to develop pleural effusion. Definition. Definition of the thoracosynthesis is also known as pleural fluid analysis is a procedure in which a needle is inserted through the back of the chest wall into the pleural space, a space that exists between the two lungs and the anterior chest wall to remove the fluid or air. Pleural fluid analysis is the microscopic and chemical lab analysis of the fluid obtained during thoracosynthesis. Thoracosynthesis is a procedure in which the chest wall is punctured for aspiration of pleural fluid. Is a procedure in which the chest wall is punctured for aspiration of pleural fluid. It is used to determine the etiology of pleural fluid for diagnostic thoracosynthesis. To relieve dyspnea caused by pleural fluid, it's called therapeutic thoracosynthesis, and occasionally to perform pleurodisease. Next, discussed about the indications. The indications divided into two types. One is the diagnostic and another one is the therapeutic. First, we have to see to the diagnostic indications of the thoracosynthesis. Determination of pleural effusion etiology. Example, transudative versus exudative. Usually require the removal of 50 ml to 100 ml of pleural fluid for laboratory studies. Most new effusions require the diagnostic thoracosynthesis and expectation being a new effusions with a clear clinical diagnostic. Example, congestive heart failure with no evidence for superimposed pleural space infections. Next, therapeutic thoracosynthesis. Reduce the dyspnea. Dyspnea means difficulty in breathing and respiratory compromise in patients with large pleural effusions. This is typically achieved by removing a much larger volume of fluid compared to the diagnostic thoracosynthesis. Next, contraindications of thoracosynthesis. First one is the local infection. Local infection over propose the site of thoracosynthesis. Example, cellulitis or herpes zoster. Select another entry site. Uncontrolled bleeding. Coagulopathy is a relative contraindication. Some data suggest it is safe to perform thoracosynthesis in patients with mild PTT elevations. Contraindication. Cautions must be exerted when the performing thoracosynthesis in mechanically ventilated patients. The positive pressure of the ventilator may expand the lung to greater than normal values, increasing the potential risk of pneumothorax. Pneumothorax means presence of air in the pleural space. Then ultrasound guided thoracosynthesis is recommended in these situations. Differ. Thoracosynthesis in patients with severe hemodynamic or respiratory compromise until the underlying condition is stabilized. Next, purpose. Purpose of the thoracosynthesis. Thoracosynthesis may be performed for diagnostic and or therapeutic reasons. The diagnostic use of the thoracosynthesis involves pleural fluid analysis to distinguish between the exudate, which may result from inflammatory or malignant conditions, and transudate, which may result from failure of organ systems that affect fluid balance in the body. Disease analyzing aids to determining the cause of abnormality. For example, pleural effusion, infection, tumor. Tumors sometimes of tumors spread the lungs or pleura, the lining of the lung of the chest wall. Thus, can cause fluid to build up in the chest. A thoracentesis may be done to help to make diagnosis. Fluid that is drained can be examined in the laboratory to see if cancer cells are present. This type of pleural effusion is called malignant pleural effusions. The term MPE. Possible complications. The most notable potential complications after thoracentesis development of a pneumothorax. Pain during the placement, bleeding during the insertion of the needle, a blood vessels in the skin or chest wall may be accidentally nicked. Bleeding is usually minor and stops on its own. Air was aspirated from the pleural space during the procedure. The patient develops chest pain, dyspnea or hypoxemia during or after the procedure. Multiple needle insertions were required. Other complications associated with thoracentesis, coughing, localized infection, hemothorax and intra-abdominal organ injuries, air embolism and post-expansions of the pulmonary edema. Post-expansion pulmonary edema is rare and can most likely be avoided by limiting therapeutic aspiration to less than 1500 ml. Next, we discussed about the procedure. First of all, equipments. Pre-packaged kits are typically available for the procedure. You should be familiar with the type of used to particular institutions. Antiseptic solution, sterile gauze, sterile traps, sterile gloves, syringe and 22 and 25 gauge needles for local anesthetic injections. Local anesthesia, 18 gauge over the needle catheter, large syringe 35 to 60 ml for aspiration of pleural fluid, 3-way stopcock, high pressure drainage tubing, sterile occlusive dressing, specimen tubes, 1 or 2 large evacuated containers. Next, position. Position the patient seated on the edge of the bed, leaning forward with their arms resting on the bedside table. If the patient is unable to sit, the lateral recumbent or supine positions may be used. IV axis. IV axis should be established before the procedure in most of the cases. If during the procedure of the thoracentesis, sometimes the patients the vital signs are unstable. Anyway, they have to need for some of the IV fluids or inotropic drugs they have to administer for these patients. Anyway, you have to pre-plan, they have to put for IV axis in the patients. Then atropine should be on hand in case of profound vasovagal response, and supplemental oxygen should be administered throughout the procedure as necessary. Nursing intervention of pre-procedure. Check the doctor's order, identify the client, ask the patient to sign the consent form that gives you a permission to do the test. Read form carefully and ask questions if something is not clear. Explain the emphasis the importance of the procedure. Inform that she will be experiencing mild pain on the site where the needle was pricked. Inform the client that the procedure takes only few minutes, depending primarily on the time it takes for fluid to drain from the pleural cavity. Inform the client not to cough while the needle is inserted in order to avoid puncturing the lung. Explain when and where the procedure will occur and who will be present. Explain the procedure to the patients and so reinforcing with what the physician has previously explained to the patients. The patients may be receive a sedative prior the procedure to help the patients relax. Ask the patient to remove any clothing, jewelry or other objects that may be interference with the procedure. The area around the puncture site may be shaved. Vital signs: heart rate, blood pressure, breathing rate, and oxygen level are to be monitored before the procedure. Support the client verbally and describe the steps of the procedure as needed. Vital signs: heart rate, blood pressure, breathing rate, and oxygen level are being monitored during the procedure. The patient may receive the supplemental oxygen as needed through a face mask or nasal cannula tube. Observe the client for signs of distress such as dyspnea, pallor, and coughing. Place the patient in a sitting position with the arms raised and resting on the overbed table. The skin at the puncture site will be cleansed of the antiseptic solution. The patient will receive a local anesthetic at the site where the thoracentesis is to be performed. Do not remove more than 1000 ml of fluid from the pleural cavity within the first 30 minutes. Place a small sterile dressing over the site of the puncture. Observe the changes in the client cough, sputum, respiratory depth and breath sounds, and note complaint of the chest pain. Position the client appropriately. Some agency protocols recommended that the client lie on the unaffected side with the head of the bed elevated 30 degrees for at least 30 minutes, because this position facilitates the expansion of the affected lung and eases to respiration. Positions of the patients in the side-lying position with the unaffected side down for an hour or longer. Include date and time. Perform the primary care provider, name, the amount, color, and clarity of the fluid drained, and nursing assessment and interventions provided. Transport the specimens to the laboratory. The dressing over the puncture site will be monitored for bleeding or other drainage. Monitor patient's blood pressure, pulse, and breathing until or stable or unstable. Document or relevant information. Then next, analysis of the pleural fluid. The pleural fluid should be sent for the following investigations if its etiology is uncertain. First, cell count and differential, then protein level, lactate dehydrogenase level, pH, cytology, culture and sensitivities. Cell count and differential, protein level, lactate dehydrogenase level, pH, cytology, culture and sensitivities.